Does testosterone replacement therapy increase the risk of prostate cancer? Presenter this today will be Dr. Salamatov, who will be talking about that topic.
Hi, so I'm Salamatov. I'm the first-year medical resident. The topic today is going to be TRT and basically increased risk of prostate cancer, if that's a myth or not. So I think starting off with a good quote, I found this quote online by John F. Kennedy. He said basically the great enemy of truth is very often not the lie, but the myth, which is more persistent, pervasive, and unrealistic. I found this really nice graphic which shows PSA testing and kind of the incidence of prostate cancer. So over the years, you kind of see the incidence of prostate cancer kind of creep up. We would expect this with an aging population, but we also see this really big spike where PSA testing was licensed. So that kind of showed basically that a lot of people that were previously undiagnosed were diagnosed, and then it kind of fell back down to a basal level. So prostate cancer in general, it's a pretty important health disease. So it accounts for 29% of all cancers in men and 11% of all cancer deaths. So annual incidence is 160,000 per year, accounting for 27,000 deaths per year as well. Some of the risk factors are older age, family history, African American ethnicity, obesity, and smoking. And notably, BPH, vasectomy, and sexual activity are not associated with prostate cancer risk. And so just moving on to the next slide. So the myth really, I think, originated, there's a long history of it, but it originated with this guy, Dr. Charles Huggins. So he was from the University of Chicago, and he published a series of 3 papers that basically showed that men with metastatic prostate cancer basically had some level of remission after full orchiectomy, and also with estrogen treatment. And he also showed an analogous relationship in breast cancer, so we'll kind of call this the Huggins myth. And this is the original paper where he published it. So he actually looked at alkaline phosphatase as a marker. So he just basically took people with, metastatic prostate cancer and just, performed orchiectomy or treated them with estrogen replacement therapy. And basically they found that, their alkaline phosphatase decreased. So I think the first question really is, higher serum testosterone level really associated with an overall increased risk of prostate cancer in observational studies? So a good study that I found on the topic was this one. So it was published in 2018. It's a European study where they looked at 20 prospective studies and they kind of pooled analysis of them. So these are all the studies that were individually done, but as you can see, the numbers are not overly big. And so what they decided was to reach out to all the principal investigators and kind of do a pooled analysis of this. And they ended up with almost 7,000 patients with prostate cancer. And 12,000 controls. And basically they divided them up based on their percentile of their serum testosterone into 10 groups. So 10th percentile, 20th percentile, and so on. And so this graph really shows your odds ratio of getting prostate cancer over the follow-up period. And so you could see based on the different percentiles of testosterone, there was no difference in terms of your risk for developing prostate cancer in the future. The other question would be, is serum testosterone level associated with an increased stage or grade at the diagnosis of prostate cancer? So one of the studies that I looked at was in 2006, and this was a pretty good study. It essentially looked at, basically it was a cohort study which enrolled patients between 1990 and 1994. It had a total of 17,000 men, and it excluded men with prostate cancer at baseline, and it had a follow-up period of about 12 years. And so these are kind of the baseline characteristics of those people. And so they stratified them based on the aggressiveness of the prostate cancer that was diagnosed. And so what you can see here is they also divided the people based on their testosterone percentile. So they looked at the first quartile, second quartile, third, and fourth. And they looked at the relative risk of developing aggressive versus non-aggressive cancer, prostate cancer. So, in relation to basically the lowest percentile of testosterone, you could see there was a relative decrease in the risk of getting aggressive prostate cancer, actually. So the relationship is inverse. And you don't really see that same relationship with non-aggressive cancers, which I think are less problematic in general. The other study that looked at this was published in 2011 in Cancer, basically also kind of looking at the same thing, but they looked at basically patients presenting for a radical prostatectomy at a single center. And so they measured their pre-procedure testosterone levels, and also they graded their cancer based on the morphology and the pathology. So they had a total of 655 patients with a mean age of 65, so pretty much the average kind of prostate cancer patient. And this is kind of the breakdown of all the different the diagnoses that they had in the study. And so if you actually looked at the predictors of high-grade prostate cancer, HGPCA, you actually saw that total testosterone was not a predictor of high-grade prostate cancer, but a lower serum testosterone, as seen over here, was associated with a 2-fold and a 5-fold increased risk of aggressive high-grade prostate cancer. And this was a kind of a dose-response relationship where the lower your testosterone level, the higher your risk for high-grade prostate cancer was. And you also saw this same relationship in multivariate analysis where you control for baseline characteristics like age, BMI, and PSA levels. So, if prostate cancer is androgen sensitive, which we know it is, why is there no increased risk? I think that's the real question. I think going back to kind of biochemistry, you see that the androgen receptor actually demonstrates kind of Michaelis-Menten type kinetics where it saturates with basically specific binding, and that specific binding is the thing that actually triggers transcription and translation at the nucleus. So you see that kind of black solid line, it kind of tapers off, and the taper off point is right around where the physiologic level of testosterone is. But you also see this kind of non-specific binding kind of continue to go up, which doesn't actually lead to any increase in transcription and translation in the prostate cells. You also see the same thing with PSA levels. So if you actually look at men's PSA levels and look at their total testosterone levels, you see there's a pretty linear association with total testosterone levels and their PSA level below 300 nanograms per deciliter, which is our cutoff for hypogonadism. However, at physiologic ranges, there's no association between your testosterone level and PSA levels. This basically tells you that increased testosterone does not lead to increased transcription and translation and subsequently PSA levels in the serum. The next question I think that's pretty important to address in this topic, so does testosterone replacement therapy actually in hypogonadal men increase the risk of prostate cancer? Because that's really who we would be treating for this. So the first study that I wanted to take a look at was this study, which took a look at 553 patients. It was studied in the Aging Male in 2017. Pretty good study, and it was a cross-sectional study actually, which took place between 2008 and 2013, and recruited a total of 553 men with a mean age of 61. This was a single-center study, and they basically divided these men into 3 groups. These are men, by the way, who are undergoing a prostate biopsy for whatever reason. So they divided these men into 3 groups: eugonadal men, meaning men with testosterone level of greater than 350, untreated hypogonadal men with a mean testosterone of 200, and treated hypogonadal men, basically, who had been on some sort of testosterone replacement therapy before this. And these are kind of the numbers that they got, which was super fascinating. Proportion of men diagnosed with prostate cancer after this prostate biopsy was a lot lower in the hypogonadal treated men versus the hypogonadal untreated men had a much higher incidence of prostate cancer in this group. And lastly, the eugonadal men kind of were between those two. And if you actually looked at the Gleason score at prostate cancer diagnosis, you saw that the Gleason score was a lot lower in men that were hypogonadal but treated. But it was pretty high. This is percentage of Gleason score greater than 6. Almost 60% of those with hypogonadism that were untreated had a high Gleason score. The next study that I wanted to look at was published in 2021 in The Lancet, and they looked at testosterone replacement therapy. It was a pretty big trial, so that's why I wanted to include it. But their primary outcome was really the oral glucose tolerance, but they also had prostate cancer as one of the safety events. So this study, it took about 1,000 men and randomized them 500 and 500 respectively into testosterone replacement and non-testosterone replacement. The study took place between 2013 and 2017. And they basically included men with an impaired glucose tolerance, elevated waist circumference, and low testosterone, not necessarily hypogonadal, but low at less than 400. And they received testosterone and ducanate for every 3 months for 2 years. And their primary endpoint, did show a 40% reduction in, in incidence of diabetes, essentially. So it was a pretty significant trial for that. But in terms of their safety events, they only observed about 5 prostate cancers in the placebo group and actually 4 prostate cancers in the treatment group. So there was no significant difference, even with patient follow-up of 2 years of over 1,000 patients. The other study that I wanted to look at was, I think this is probably the best study on the topic, and a lot of the meta-analyses didn't actually include it, and so this one is the more recent one. It was published in JAMA. It really looked at, it's kind of a sub-analysis of the TRAVERSE trial, but here they specifically took a look at the safety of testosterone replacement in prostate cancer. So the design of the study was that they took place at 316 U.S. sites between 2018 and 2022, and they enrolled basically men with hypogonadism and an elevated cardiovascular disease risk. And they took about 5,000 men and randomized them into testosterone replacement or no testosterone replacement. And they titrated the therapy to a testosterone level of 350 to 750 for 2 years. And this is the primary kind of outcome of this study. They did observe about 12 prostate cancers in the TRT group and 11 in the placebo group. But with over kind of 5,000 patients in 2 years, this is what they had observed, and there was no significant difference between men being treated with TRT and men being treated with placebo. Some of the other ones, there was kind of maybe like a trend towards being positive of like an invasive procedure for BPH, but we also know that the TRT leads to kind of increased iatrogenic risk. And I kind of did want to close off with kind of the American Urologic Association guideline, which basically says that there's really an absence of evidence linking testosterone replacement to prostate development of prostate cancer. And these are, the professionals that deal with it the most, and I would say they have the highest expertise in the field in general. And this is kind of their strong recommendation, grade B level. That's going to be it.
All right. I guess before we vote, anybody have any comments or questions?
The question, I guess, maybe through your research is, the incidence of prostate cancer in hypogonadal men at autopsy, say an average 60-year-old. My understanding is at autopsy about, at that age or 70-year-old, about 70% will have prostate cancer at biopsy. So most of the studies were 3 years, maybe 4 years at best. And I'm not sure that there's evidence that this exposure time would maybe unmask that. Just 3 years. So that's the tough thing with a lot of the studies. Long-term effects would probably, I think, need to be done.
Just to summarize your question for the people at home, basically you're questioning whether some of these studies are a long enough duration to really uncover the development of prostate cancer. Which can be much longer than a couple of years.
A huge recognized
Yes.
problem in this
Okay.
diagnosis, and so many people already may have it, and so that's it'd be hard to tell who carried it before the study even happened. Before this, because if they did random biopsies at initiation into the study, but there's probably, and there weren't that many events in the trials, some of them that you presented that would be significant, but I just think the study duration is too short to really answer the question you're proposing.
Yeah, there was one that was about 12 years, and that was from Australia, and that didn't actually show any significant difference. But yeah, I think that was one of the main drawbacks that I saw in the trials. These are expensive trials to run. You have 5,000 patients, and you're randomizing them for 2 years, and you're giving them therapy. I don't know what budgets these studies have, but following them up for 30 years seems pretty difficult to do. logistically speaking. So I do hope that, in the future we do have some sort of registry where we're able to follow long term and see what their outcomes would be. But yeah, I think based on the available evidence so far, I think there is nothing to really indicate that there is an increased risk of prostate cancer.
So last month when we talked about estrogens and breast cancer, the the Women's Health Initiative study, which was started like more than 20 years ago, their initial data was published, I think, in 2 or 3 years, that there was no increased risk of breast cancer from estrogen hormonal replacement therapy. And they've actually followed those women for 20 years now, over 20 years, and the 20-year review showed basically it was even less than in the original study, a lower incidence in the subsequent studies. So you never really know, I agree. And that was one of my questions also when I was looking at all the data. These are relatively shorter term follow-up, except for the one study that he mentioned that was 12 years, which didn't show any increase. And a lot of the data actually shows that not treating hypogonadal men actually have worse outcomes and higher grade tumors. So at least the evidence seems to be strongly leaning in that direction at this point.
I guess I had another question about this field, in that, the reduced testosterone, my understanding is some of that may be related to the metabolic syndrome and obesity, which is a huge confounding variable in colon, breast, prostate. I think pancreatic cancers incidents are all increased, thought related to this metabolic disarray, or whatever's causing this metabolic disarray we see so prevalent. And so also metabolic syndrome, I believe, is thought to reduce testosterone levels. So you have these patients who may be hypogonadal that start on testosterone, but their risk for cancer may be completely unrelated to it. I don't know if you came across that argument as well.
Yeah, I mean, metabolic syndrome is definitely related to, hypogonadism. Yeah, I think his question was, that it's a big confounder, metabolic syndrome, and impaired glucose tolerance tests and waist circumference and all those kind of markers of diabetes have been shown, and obesity have been shown to reduce your testosterone levels, and it's a big confounder. I think one of the reasons why it's important to look at randomized control trials where you're randomizing these confounders away through using a rigorous methodology. And the trials that, the RCTs that I did present, they had sizable amounts of patients, so you would imagine that diabetes and other metabolic derangement would be kind of randomly sorted between the two groups, and so you wouldn't really have any effect of that in the RCTs at least. But yeah, with TRT and, one of the studies that was kind of presented here, it did show significant actually improvement in oral glucose tolerance and incidence of diabetes in patients actually treated with testosterone. So in fact, I think it could actually be used as a treatment for prediabetes, where the effect size is pretty big. It's about 40% reduction in relative risk. So.
The only other thing I was going to say, I'm sorry to keep, I was very interested in your topic as well, but just the super high incidence among young men with low T, as we evidenced by the comedian, 40 years old here. And then, so these meds would be meds someone might be on for 20, 30, 40 years with possibly not just this as the only side effect. So it does require a high degree of evidence for safety, I would say.
Yeah, and I think the official guidelines from ACP and AUA kind of do recommend doing a trial of 12 months of treatment and then seeing if the hypogonadism resolves at that point, and then reassessing kind of, treatment as you treat. So you wouldn't just put somebody on it for 20 years and just let them cruise, but you kind of every 12 months reassess, do they actually need this, and withdraw the therapy and see if they go back to being hypogonadal or not.
All right, well, it's time to vote. Testosterone replacement therapy increases the risk of prostate cancer. How many think this is true? How many think it's plausible? 2 or 3. How many think it's busted? Well, it looks like the majority, so I guess we'll go with busted. All right, we're busted.